I'm Bob Rocker, founder and president of AgeWise Colorado, and I would like also to introduce Barbara Boyer, who is our executive director. I'm going to spotlight Barbara so everybody can see Barbara. Okay. So,
Hello.
All right, as it says here on the screen, this is our 36th webinar that we've had in the last 2 years. And they cover a very wide variety of topics. They've all been recorded. They're all on our website. Several have been translated into Spanish, as this one will be today. And our topic today is mobile eye care, vaccinations, and diagnostic testing. We have two guests, two panelists. First would be Dr. Jessica Schuman. And she is the owner of Mile High Senior Eyecare, which is a mobile optometry practice providing on-site medical eye care to senior communities across Colorado. And you can see there's her contact information is there. And secondly, we have Margie Guerrieri. Pronounce your name, please, Margie.
Guerrieri.
Guerrieri. That's
Thanks,
what I
Bob.
thought it was. Okay, sorry. Who is with OnSite Health Solutions for Novir. So Margie became focused on serving our aging population, found her passion after placing her dad into long-term care, where she learned firsthand the multiple decisions that a family member makes throughout the care journey. And I appreciate that, having been there myself. And there's Margie's contact info. So who are we at AgeWise Colorado? I've mentioned this a little bit previously. We are working to become the premier nonprofit information embedded resource provider hub for aging Coloradans and their current and future caregivers. So we estimate serving about 3 million people here in the state of Colorado who are over the age of 40. I skipped the demographic slide for today, but I will tell you this, that because a lot of people are surprised to know that last year, for the very first time, the number of people over the age of 60 exceeded the number under the age of 18. And that is a trend that is going to continue for the next many years, many decades. Briefly, here's how we see ourselves. We're this connector between, we estimate, roughly 3,000 different organizations who can help with all aspects of the aging experience here in our state, and connecting those to the 3 million people that I mentioned earlier who are over the age of 40. These are our planned webinars, obviously today's, and then we have 3 more that we've scheduled. We'll be scheduling a few more probably next month. We'll get those added to the schedule. But you can see here, we're going to be talking with AARP about the many different things AARP does that most people are not aware of. And then we have a couple of others, including Medicare updates, which many people are interested in. Okay, so I'm going to end this. And then what I'm going to do now is make a little bit longer introduction to Jessica Schuman, and mention that the goal of her organization, which is Mile High Senior Eyecare, is to give patients, especially those who have mobility or access issues, the same quality of care that is provided at a traditional doctor's visit, offering state-of-the-art portable equipment and providing both glasses fitting and adjustments on site, striving to bring quality eye care to your doorstep. So Jessica, please tell us more about what you're doing and why you're doing it and how you started doing it.
Awesome. So I am Dr. Jessica Schuman, and I have been an eye doctor or optometrist for about 12 years now. And I'm originally from New York. And since I graduated, I've been doing various private practices. And then 5 years ago, I moved my family over to Colorado. kind of your typical answer, the people, the mountains, the sun, everything. Love it here. And so since coming here, I actually started with a different optometrist, kind of doing a dry eye practice, and we were really successful, and that was wonderful. And then while I was doing that, my father-in-law, who has Parkinson's, we were thinking of moving him into a rehab because he had an incident. And long story short, I started calling places and realized that no facilities had any eye care. It was just very seldom that anyone said yes. And then it was sort of this seed that just kept on kind of planting in my brain. And I'm like, okay, I'm going to work 4 days, 3 days, 2 days. And then I just really wanted to get this off the ground and do this. So I was raised very closely with my grandparents. My grandfather was in a home many, many years ago, and lost his vision. So being able to kind of combine my love for optometry while being that care that people so desperately need, is kind of the crux behind Mile High Senior Eyecare. So, and because I'm doing this with many years of experience, I think I did really well with purchasing my equipment. And all my equipment is really awesome and lightweight and portable and advanced, where, 20 years ago, or even less than that, if you were getting an exam in a home, we'd sort of have to go backwards in optometry with the equipment to sort of do it. Whereas now we don't. We're going ahead. I have a retinal camera that's really, nice and lightweight. We can keep documented photos, as well as coordinate with other physicians by sending photos encrypted and all that as well. So I love this. This has been so fulfilling. I do exams at people's homes as well as senior centers, long-term care facilities, all of that. So I put a little PowerPoint together, just to kind of put things in order. So let me do that a minute. This is what we're going to talk about a little bit. And just this photo, that's a trial frame. I actually use that all day, and it's amazing because you can actually see, they can see what they're seeing in real time. We can make sure their balance is good, all of that. All right. So, we kind of said a bit of this. I do on-site exams, housebound people with mobility challenges, developmental delays. Because my equipment, and this is something I'll talk about, can be used on anybody, whether they are verbal, whether they are sitting up. It's the type of thing that anybody can have a dignified exam. So if anyone's even overweight, disabled, has a back issue, it can be really hard to be in the traditional equipment. So, alrighty. And yeah, so our mission: provide the highest quality vision and eye healthcare while maintaining a comfortable, professional, patient-friendly environment. The goal is to give patients who may have mobility and access issues the same quality of care as if they're in the doctor's office. We pretty much go everywhere. We're really around Douglas and Denver a lot, but we go everywhere. And some facilities I set up monthly. Other times they call me when they have people that are needed. The insurance is accepted pretty much everything except for Kaiser and the Denver health plans. And if I'm going to someone's house, I typically charge $200. And if we're adding it to a facility, it'll sometimes be $100, just because I'll already be on site. So just so you know. All right, so these are a lot of statistics basically saying that national studies indicate that vision loss is associated with a higher prevalence of chronic health conditions, death, falls, injuries, and the prevalence is 3 to 15 times higher in long-term care facilities. And this isn't any surprise, right? It's very difficult for them to get access to care. So the potential benefits of optometrist-led eye care programs for residents in retirement homes and long-term care facilities are far-reaching. So yeah, we know this because we want people ultimately to be seeing their best so that they can do their puzzles and look at their phone and watch TV and not fall. So all those things are super important. And conditions we manage: cataracts, glaucoma. I have equipment to do everything except for surgery, which is an ophthalmologist, and that's when we refer out. Conditions that often require routine monitoring: diabetes, high blood pressure, high cholesterol, MS, autoimmune conditions. I think if we go down that list, there are a lot of people you could think of that have that. So that pretty much tells you that routine monitoring is pretty much necessary for every resident and every senior. These are just some examples that I put together. If any senior you know was like, hey, I think I see double, well, they could be seeing double vision. They could also be having astigmatism, which is as simple as a prescription. And that's just a prescription where the eye is more of an oval and less of a circle. And they can sometimes see like they're seeing double. Diabetic retinopathy kind of looks like a dirty windshield. Glaucoma is sort of this narrowing in. Macular degeneration is a black spot in the central vision that gets larger and larger. A cataract is kind of a general film. And a hemianopsia, which can happen from a stroke or a vascular event, is when they're missing kind of half their field. So just something to be aware of if they ever mention that to you. I'm not going to read all this, but lots of medications can affect the eyes, and we want to be checking that. Some of the technology I have that I'd like to mention, this picture at the top right, that's called an autorefractor, and that's to check the prescription. The senior just looks down the barrel and they see a little house that gets clear and blurry, and it takes, about 10 seconds or so, and I have the prescription. It's pretty dead on also. I also have a nice portable slit lamp. That's like that big machine you lean into at the optometrist office. Now it's kind of this little handheld machine. This on the bottom right, that is to check the pressure. That's a test for glaucoma. And now we have one where somebody completely flat, and we can still get an accurate pressure reading. This is important, if people are laying down in bed, infirmed, all kinds of stuff, we can just make sure that they're doing okay. All right. And then the last is that retinal camera I told you about, which is just a lot of fun. I would say like 8 out of 10 people, I don't even need to use eye drops in their eyes. I can get a nice full view because it's just that good. So people really like that. All right. So the exam, we really check everything. So visual acuity, we check the prescription, eye muscles, the visual field, the side vision, the front of the eye, the back of the eye, all of it. So, all right. Something else I do want to say on this. Okay. So when somebody does have to go out to the eye doctor, they then have to go out again for the glasses. And another thing is that when they are going out to the eye doctor, when people take medical plans, they usually charge for the prescription anywhere between like $25 and $40. I don't charge that. That's part of the exam. That's why I'm doing it, is to get the patient seeing the best they can, as well as the retinal photo, which is a photo of the back of the eye. Most places charge between like $30 and $100 for a picture. That's also included in all of the exam. I know seniors are on fixed income, so I try to do everything within, the model of insurance, and really not send any bills and, get anybody stressed out. So if you have any other questions, you can reach out to me at Dr. Schuman at mhseye.com, or there's the phone number, website. We also do exams in Spanish. And so, yeah, would love to serve any seniors and help them see their best. Thank you guys for your time.
Thank you, Jessica. So before we move on, does anybody have any questions of Jessica? Anybody on the call, you can unmute yourself and ask, or we have a note in the chat saying eyeglasses and eye exams can be itemized on a tax return. That's from our CPA friend, Rick Martin.
Yeah, thank you.
Mm-hmm.
Yes. And to that note, I've also sourced like very low priced glasses, so that, nobody is really prohibited by that, usually. And there are some vision grants where we can help people who are. So, yeah. Okay.
I had a question, and that is, how often should people be getting these eye exams?
That's a great question. So they should be getting them every year. And that's, I meant to mention this. I don't take vision plans, because vision plans, you have to do it every 1 or every 2 years. And that's not really applicable to a lot of seniors. They have a lot of health issues, like I discussed. They should be monitored every year to make sure that they're in optimal health and that they're seeing their best. So good question. And because of the medical plan, they can see me today, tomorrow, next week, and they could see someone else the week after that. So they don't have to get concerned on using that one exam or any of that. So, you know, when I start with a facility, I'm like, if we take the plan, which mostly we do, let's just go door to door and make sure everyone's seeing their best and offer it, you know? So yeah. Thank you.
Thank you. And one last thing.
Yeah.
So you mentioned referrals.
Mhm.
So as we get older,
Mhm.
because I have having had some personal experience with this, you know, we do develop cataracts. I mean,
Mhm.
right? I mean, they happen to everyone, I
Yep.
assume. Yes. So at some point, you have to make a decision about
Mhm.
if you get cataract surgery, but when to get it.
Right.
Can you talk a little bit about that?
Sure.
How you
Yeah.
advise?
So what cataracts are, let me just rewind a second. So we have a lens inside of all of our eyes, and that lens just absorbs all the light throughout our entire lives. So does our skin, and that's why our skin technically darkens as we get older. And so does this lens inside of our eye. And so it gets kind of a light yellow, a dark yellow, a light brown, a dark brown. When it becomes very dark, it's difficult to see, and we have to take it out. From the patient's perspective, they're going to just be like, hey, my eyes are getting blurrier and blurrier. Let's go to the doctor. Let's see if we can change the prescription. And then just one day we say, like, hey, we can't change the prescription. It's beyond that point. We need to take the lens out and put a clear one in. And when they put the clear one in, they actually typically correct for that distance prescription. Depending on if someone has astigmatism or whatnot, they may end up with glasses, they may not. But it is much better for them to have that done. So typically it's like a very easy outpatient thing. So first they see the surgeon for a preliminary visit where they just get a bunch of measurements. Then they go in for the surgery, which is about 30 minutes. And then there are some follow-ups. So I'm able to do the follow-ups if the patient would like that. A lot of times the facilities, the surgical facilities actually do their own. So it really depends. We can coordinate that. But the question is when to get the cataracts out. So depending on the person, sometimes where the way that the cataract works when it darkens, it doesn't darken completely equally. Meaning you have this circle, let's say, you can have a dark spot here and not a dark spot here. So when light hits your eye, you can have a lot of glare depending on where the cataract is. So some people don't even have that bad of vision, but their glare is so bad. They're like, I can't drive at night. And so they will get it done a little bit sooner. Other people, once they hit that 2030, 2040, it's like they want to do it. So it really depends. I see really people all along the scope of functioning. So there are some people that are 99 years old in a home who, if I can get them from 2060 to 2040, like that's enough for them and they'll be pretty happy and they don't necessarily want to go out and do the surgery. So it's kind of taking a lot of factors in and really discussing it with the person and their family and kind of making a decision. So sorry, it's not a black or white answer on that one.
Well, no, I wasn't expecting a black and white answer, but so
You bet.
that,
Yeah.
that was a good answer. But
Thanks.
okay, well, thank you so much. Are there any other questions before we move on to our to Margie?
Thank you. So, Bob, I'd like to thank you and Barbara and the rest of the AgeWise team for inviting us to come on today and talk about vaccine preventable diseases and the importance of that and how we can help keep our loved ones, especially seniors living in a communal environment, safe. I'd also like to welcome my teammate, Jean Callison. Jean is an RN and also an infectious disease nurse. And so I might be calling on her for a little bit more specific information as we go through, since I am not a nurse, everyone. But let's get started. So Novir is a on-site health services company. We provide a whole plethora of services from a biomedical and biotechnical engineering perspective. But what I'm going to be speaking with you today about is how we can support seniors by coming on site with preventative care that is vaccine focused. So NOVIR means no virus. We're headquartered in Milwaukee, Wisconsin. We got our start during COVID. And so basically, we provide on-site vaccination services, virtual proctoring, testing and screening, biometric testing, and education for our senior living employees and employers. We really like to help reduce emergency room visits and hospital stays. And that's really the importance of promoting vaccine preventable diseases and wellness, because it does eliminate financial burden, not only just in the general population. Included at the tail end of my information is a study that was done on vaccine preventable diseases by the Department of Epidemiology at Children's Hospital in Colorado. And so it's really, really important to note that in 2021, and the report came out in 2022, that between influenza, pneumonia, Hep B, shingles, and COVID, over $4.6 billion was spent in the state of Colorado on diseases that could have been prevented. So it's really, really important that we continue to help reduce the spread of vaccine preventable diseases. So we serve multiple communities, but my focus, along with Jean's here in Colorado, is senior living communities, post-acute, long-term care, any type of a residential rehab facility, etc. So the cost of diseases is very, very high. It's estimated at $27 billion across the United States. Only 1 in 4 adults are up to date on the 4 most recommended vaccines, and that's the flu vaccine, pneumonia, Tdap, obviously, and shingles. I can tell you that this year, the CDC and all of the medical community is calling this upcoming flu season a tridemic. And basically what that means is that there are multiple bacteria and viruses that will be converging all at the same time from this time in late September all the way through to the end of March of 2024. And so the CDC is recommending that our seniors especially get vaccinated with the flu vaccine, with the new COVID monovalent booster that will be coming available here in the end of September, and then also what's called the RSV. And RSV is a upper respiratory virus that very much mimics a very bad cold and flu symptoms with a high fever, but then can move into pneumonia. It's highly spreadable. So you're probably going to be seeing and reading a lot more about the tridemic and how getting vaccinated will help to prevent the spread of that going through into 2024. So the other thing too is that the COVID vaccines really did positively impact the pandemic and helping. I know we heard a lot about people that really got sick, but it did eliminate hospitalizations across the board and reduced illnesses and the spread of it. Thus, the PHE, or the public health emergency, is no longer in place. However, we are recommending that people do get the monovalent booster, especially if you're over 65 for this year. So again, 5 reasons why it's important to get vaccinated. I mean, disease is still a threat all over the world, and vaccines have been around for quite a long time. It's a great way to protect yourself and your loved ones, because your body can create protective antibodies to fight off the infections. You also help by not spreading the diseases to other people inside of the community. So that's really an important thing. Vaccines are safe, and you can be monitored to make sure that they're providing you the best benefits. And then, of course, in senior living and long-term care and any healthcare related, there are certain regulations for the state and the county health department. And so certain vaccinations for team members, as well as for residents living in communal settings, they have to be vaccinated, or it's recommended that they get vaccinated to meet the compliance of the state and local health departments. So these are the types of vaccination and testing services that we offer at Novir. And so we will come on site with a team of vaccinators and schedule a clinic to be held on site inside of a community or a healthcare setting. And so we bring these types of vaccinations and help to vaccinate all of the residents and team members. And so we work with each individual community or healthcare setting to be able to do that. We also provide other testing services that are beneficial as well. And then we offer some additional services. So there's some new regulations that have come out, particularly across the country, that have to do with OSHA compliance right now. And so we are also doing some specialty, what we call respiratory fit testing, that is to help make sure that the team members that work inside of healthcare have been fit tested properly to make sure that if there is any type of an outbreak, that a mask that they're wearing would properly fit them and protect not only them from any airborne viruses, but also protect their one-on-one patient and resident care.
Margie,
Yeah.
could you just put up that slide that shows all the different vaccinations that you provide? Because you haven't been sharing your screen.
It never showed up. It never showed up, Margie.
Oh, you're kidding.
No.
So you said you were going to talk, so I didn't know if you were intending to show everything.
I'm like on slide number 8 now.
Oh
But
gosh,
it's okay.
none of them.
If you just put up the one slide that
Let me go back and share.
No, it's okay. But the primary thing I think is the slide that you were showing, that you were
There
talking
you go.
through.
It's going to be up in a minute. There you go.
Yeah,
Here it is.
that
I'm
one
so
right there.
sorry, you guys. I just went through like 5 or 6 slides. How boring that you had to just hear me sit and talk the whole time. So
Yeah,
thanks for bringing that to my attention, Bob. But yes, these are
It's okay.
can you see this slide now?
Yes.
Okay. I'm going to try and put it back on full screen again to see if you can see that.
There you go.
Okay.
Yes.
Good.
Thank you so much. So again, these are the vaccinations that we will bring a team of vaccinators on site to assist in senior living, skilled nursing, long-term care, post-acute, rehabs, just to support not only the team members who are super busy doing one-on-one or group care, but also really for the residents. Because if you're familiar with any type of senior living, it's a communal setting. It's a beautiful place to live. There's lots of friendships that are made, and it's really important that we help everybody keep themselves safe and then keep safe and healthy the other people that they interact with on a regular basis. So that's kind of it in a nutshell. I'm going to try and scroll through and see if you can't see any more slides, because
Hey, Margie, before you move off that slide, I just had a couple questions.
absolutely.
So, what do you folks recommend in terms of the sequence of these different vaccines, and which ones are could you get a flu shot and a tetanus shot and a shingles shot all the same time? Could you talk about that a little bit, you or Jean?
I'm going to let Jean speak to that right now. I know the answer, but I'm going to let Jean talk about it since she's the nurse.
Hello, everyone. I'm Jean Collinson, RN. Well, this year, it is permissible to get the RSV, influenza, and the COVID vaccinations all at once. What we do here, depending on what vaccines you've had previously, we can look it up in the CIS system. It's Colorado system. And everyone who's ever had a vaccination in Colorado, their vaccinations are entered there. So it would depend on when you had the vaccine last. And that's pretty much it. Like Shingrix and Hep B. Hep B is a sequence. You get one vaccination, and then 6 months later you get another vaccination. Tdap and tetanus. Tetanus is usually given every 10 years or so. So it would really, and as far as the pneumonia vaccines, they're recommended, especially for people over 60. So it would require your provider to look up when you last had those vaccinations as to when you would receive another dose.
And if I could just interject, thank you, Jean. What we're currently doing, since the flu season is really coming and the CDC is recommending all 3 shots that we just discussed for to handle the tridemic, we're really working towards coming on site and helping to administer those 3 shots at one time to those people that obviously consent for it, having the shots. We will come back and provide shingle shots at another later date. We can couple that with obviously Prevnar 20, which is the pneumococcal. So again, there's a process in place, and residents and family members, or the POAs, go through a consent form, and they can check the boxes as to what they would like their resident to get. And then, as Jean mentioned, we then validate that eligibility against what's called the Colorado Immunization Information System. And every state has an immunization system. So it's not like it's just something here to Colorado, but it's, again, whether you go to a Minute Clinic, whether they go to their primary care physician, whether we come on site and provide on-site vaccination services, all that information is housed in a central repository that's run by the health department of the state. So, you know, it can be individualized, Bob, is the best way that I can explain it. But right now, our doctors, our chief clinical, our chief medical officer is recommending that to follow the CDC guidelines. I also know here in the state of Colorado, although I haven't spoken directly with him, but I have spoken to CDPHE, that Dr. Gregory Gom, who's highly respected in the industry here in the state of Colorado, has also recommended the tridemic. So, you know, again, we work with the communities, we work with their medical groups, we work with their nursing teams, and we really come up with a solution that's best for each community. I hope I answered that.
No, that's all good. I did see a comment in the chat about the fact that the COVID shot is not listed under your vaccination list. You might want to get that corrected.
Thanks for saying that. Yes, it's the monovalent. I see it under testing services. Yes, it's the new COVID monovalent, and it has not been officially released yet. So, but they're saying end of September, early October. So, thank you for that.
You're still giving the original shots too, if somebody needed one.
Actually, Jean, you can speak to that, because they are all being, recall's the wrong word. Jean, I'm gonna let you talk about what we're doing.
Can you repeat the question, Bob?
My question was, I would assume that you still can provide the current COVID shots if somebody missed
Well,
theirs.
Well, we have COVID bivalent, but that it's so close to vaccination season with the COVID bivalent. The new formulation of COVID is the monovalent, and that is the recommendation for this year for the CDC, per the CDC. That and the respiratory syncytial virus and the quadrivalent high dose for seniors. It's recommended that seniors have all three of those vaccinations this year.
Okay, gotcha. Thank you. Okay, so Margie, what else do you have here? Yeah.
I really don't have anything other than my contact information, which I'm going to page down. I hope you guys can see.
You're good now, but yeah.
I mean, the biggest advantage is that by coming on site, we save not only the team members time to prepare, but we also help the families and the residents because they don't necessarily need to leave their environment. They're free if they want to, but it's just it's a convenience for them. And then obviously that helps the community stay compliant with the regulations for the Colorado Department of Public Health. So mine and Jean's contact information is right here on the screen, Bob. And
okay.
We really appreciate the opportunity. And I'm wondering if there's any questions, any other questions that Jean and I could answer.
Yeah, we're open to other questions if any of you folks have one. Just go ahead and speak or type it in. Okay.
Thank you very much, everyone, for your time.
Thank you.
Yeah, one quick thing, just, you know, I know you talked about this earlier, but if you could just maybe reiterate, how do people pay for this? Is it all through Medicare or Medicaid? Or,
it is. We will bill directly private insurance and Medicare or Medicaid for that matter. So that's how it's paid for. And we have a small travel fee per clinic, and it's just based on mileage from our refrigerators, which has a whole chain of command process as well that we need to follow. And it's basically $1.50 a mile, just round trip, just so that we can, you know, get our materials there and our team there. So, and we work with everybody individually, so there's no surprises. Our goal is to keep everybody safe and healthy and just go on living a great lifestyle.
Very good. Well, thank you so much, Margie and Jean and Jessica. And do we have, before we close, does anybody else have any questions of any of our presenters here today? Or for us as well. So, okay. Well, thanks everybody for joining us today, and we very much appreciate it. And I hope that you've learned something that you can use over and over again. And keep these folks in mind. I know you have their contact info now, so you know how to find them. And as I mentioned earlier, we will be getting this recording posted online on our website in the next several days. It takes a little bit of time to get that done, but not too much. And then you can also see any of the other 35 recorded webinars that we have, any subject that might be of interest to you, along with about 200 different informational articles about a variety of topics too. and of course, all of our vetted service providers. So thank you once again for joining, and have a great rest of your day.
Thank you, everyone.
Thank you. Bye-bye.
Bye.
Bye.